Hello, friends. It's me again. A big thank you to Representative McBath, Representative Adams, Secretary Becerra, and Senator Booker for their remarks this morning. I am delighted that you all are here, and I am also delighted to welcome to the stage the moderator of our second panel, Deputy Secretary of Health and Human Services, Andrea Palm, as well as our panelists from the Biden-Harris administration, Administrator Chiquita Brooks-LaSure, Administrator Carol Johnson, Deputy Director Allison Cernich, and Special Assistant to the President for Healthcare, Jessica Schubel. Yes. Deputy Secretary Palm, who will be introducing each of our panelists, serves as the Chief Operating Officer of HHS, where she is responsible for overseeing the day-to-day operations of the department. Before that, Deputy Secretary Palm was the Secretary Designee of the Department of Health Services in the state of Wisconsin. Deputy Secretary Palm, it is my honor to turn it over to you now. Thank you so much.
Good morning, everybody. I feel good energy in this room. It's a lovely room to be in this morning. Thank you for having me. Thank you so much to our co-chairs, Congresswoman Lauren Underwood, who it is always a pleasure to see, as well as Congresswoman Alma Adams. I really do appreciate the invitation to be here today. We follow Secretary Becerra, which is always a hard act to follow, so those of us from HHS try not to speak after him because he really is such an authentic and intentional leader for us in the space of equity and health disparities. And so you got the heart of HHS right out of the gate, and now we'll sort of dig into the details here with you this morning. But again, want to express our appreciation to the caucus co-chairs. Their leadership in this space has really been critical to the progress we've made, to the things that HHS has been able to do based on the Momnibus and other efforts that they've really championed to give us the space to continue to do and to build this work out. And of course, I'm always privileged to sit with my colleagues and leaders from across HHS and the government. I sort of don't need to tell you the problem, but I do think it really is worth saying out loud and reminding people that right now we live in a country where a white woman and a black woman who live in the same zip code, who maybe go to the same play group, have vastly different outcomes when it comes to the birth of their children. Black mothers suffer pregnancy-related deaths, many of them preventable, at a rate that is 3 times higher compared with white mothers, regardless of education and income level. Not even Olympians are immune. We recently lost Tori Bowie, who passed away due to complications from childbirth. Her former teammate, Allison Felix, highlighted how 3 gold medalists in their 4x100 relay team committed, were wanting to become mothers, and how 3 of them suffered serious complications in that quest. And right now, black babies die at 3 times the rate of white babies in that initial hospital stay. So these are things that we are very focused on, that we know you are very focused on, and we are so grateful for your partnership in this space. And it's such a sort of dynamic contrast. We think about, for example, other work we're doing, our cancer moonshot work, which, currently incurable disease that we are putting our shoulder as hard as we can against, but it's complicated and we have lots more work to do. Whereas in the space of maternal health and morbidity and mortality, the cures are not so complicated. We know a lot of what we can and should be doing better, and that intentionality that I talked about the Secretary bringing to this work, I think is critical to how we think about moving forward. In April, the Secretary and some other HHS leaders hosted a roundtable to discuss Black maternal health with stakeholders. I'm sure many of you were with him. And two leaders from that community at that roundtable shared that in part by connecting moms with a culturally competent continuum of care, they were able to reduce their maternal mortality rate to 0, one after serving about 1,200 patients, the other after serving about 2,000 patients. Again, culturally competent care, intentionality about how we do this work. It doesn't have to be complicated, but we have to do it well and right. When Black doctors care for Black babies, their mortality rate is cut in half. At HHS, we've seen that by showing up for communities, investing in local community organizations who have that on-the-ground experience and data to back up their methods, we're building a healthcare workforce that looks like the people that we serve, where the outcomes are better, and we really do believe through this very intentional work we can save lives. So HHS has done a variety of things. Again, we'll dig into some of the details here, but we really are doing our best to make a significant down payment in recruiting and training health professionals who do look like the communities that they serve. We invested $5.5 million for our Minority Health Fellowship Program to grow a more diverse workforce to better meet the needs of vulnerable populations. And in our FY23 budget, which we are currently moving out the door, the president allocated $471 million for maternal health. Again, an important investment that we hope to build on in future budgets. In April, our Health Resources and Services Administration made available as much as $468 million in funding related to maternal and child health across several of their really critical programs. And we've been working with states to extend Medicaid's postpartum coverage from 2 months to 12 months. So far, 35 states, DC, and the U.S. Virgin Islands have signed on, but we will not rest until we get the rest of them across the finish line. Together, this group are really doing our best to lead our teams to go on offense to really tackle this crisis. And so we're looking for effective, scalable solutions. We're looking for places to make key investments to move the needle. But again, I'm going to let them speak for themselves as we dig in to some of the details here. But first, if I might introduce them, not that any of them actually need an introduction, but let me first start with our CMS Administrator, Chiquita Brooks-LaSure. She has decades of experience both protecting and expanding access to care in the federal government, here on the Hill, and also in the private sector. Our HRSA Administrator, Carol Johnson, she served at both the federal and state level. We were commiserators at the state level many, many times in the interim before returning to HHS. And she created new Medicaid benefits in New Jersey to improve maternal health outcomes. Our National Institute of Child Health and Development Deputy Director, Allison Cernich, is here with us. She has extensive interagency research experience related to reproductive, maternal, and child health. And of course, our Special Assistant to the President on the Domestic Policy Council, Jessica Schubel, who has experience working both across federal and state levels to protect access to care and to help us all do our work better. So with that, I might go straight to questions if you guys are ready for that. All right, we'll start with Chiquita. First question to you, Administrator. When you began as the Administrator of CMS, 0 states had year-long postpartum Medicaid coverage. Now there are more than 30. Can you describe the significance of this progress and really the importance of every state extending their coverage for 12 months?
Well, let me start by joining Deputy Secretary Palm and all of us in thanking our co-chairs and really thanking the work of the U.S. Congress in passing the legislation that made it possible for states to expand postpartum coverage for 12 months at a state option, so not having to go through the waiver process. And there are so many factors that go into our maternal health crisis in this country. But one of them is absolutely this notion that after you give birth, you need to worry about switching coverage. And what we know from the science is that many of the maternal deaths and many of the effects, maternal morbidity, actually occurs after baby is delivered, after the stay in the hospital. So up to at least 12% of the deaths actually occur between the 2-month and the 12-month period. And for any of you that have been new parents, you are juggling so much. I mean, I remember being in the doctor's office, trying to get my doctor's appointment while I was dealing with a crying baby, just navigating all of that. And obviously, I'm a person with secure means and health insurance. Trying to do that when you may be having to go back to work sooner than you might like to, having to navigate your household, and then having to switch your insurance. We all know how complicated that is. And so this is why it is so critical that that takes one more decision off of the parent's plate of having to make sure that they stay and maintain coverage. It's important for the parent. It's also incredibly important for the kid, because what we also know is that when parents are going to the doctor, they're making sure their children are enrolled. And so it's crucial. And we have more and more states coming in. Every time I speak, the number has popped up. We are now over 35 states that have expanded coverage, and we can't rest until we hit 50.
Thank you. All right, Carol, next to you. At HRSA, and I noted the almost $500 million across your programs, that you oversee in this space. Members of the Black Maternal Health Congress, they've appropriated really record levels of funding that we've been privileged to be able to push out the door. And so maybe I could ask you to talk a little bit about what you've seen on the ground in communities from these programs, what types of local initiatives, the creativity you've seen, how this funding really is impacting communities and families.
Thank you so much for the question, and thank you also to the caucus for your leadership on this issue, and for giving so much hope to all of us in this community who've been working on these issues for a long time. I would say it's a huge testament to the work of CMS that we have gotten as far as we have gotten when it comes to Medicaid expansion. As a former leader of a Medicaid program, who we were the second approval, on a technicality, our application might have been there first, but anyway. But everyone in this room will say, because everyone in this room knows, that an insurance card is only as good as the person as having access to quality, accessible care. And we know that for far too long, women's voices have not been heard, women have not been seen the way, women of color have not been seen the way we need women of color to be seen in this healthcare system so we get the best possible outcomes. So while we've extended access to coverage, we've been investing in the changes that need to happen in modernizing the workforce, in making sure that there are certified nurse midwives, that there are community-based doulas, that there's a workforce that looks like the community we're trying to serve, that listens to women's voices and can deliver high-quality outcomes for women. And that's what the Biden administration has been investing in. At the same time, we've been investing in what we need to do to improve quality care inside clinic walls. So we know that hemorrhage has been an issue for a very long time. We need to make sure that all hospitals are ready and able to respond when crisis situations happen. But all of our investments can't just be inside the clinic. They have to be what's happening in the community. We all know that social determinants of maternal health are what are going to drive better outcomes here. We've been able, through the Biden administration, to invest in state innovation and task force to be able to put tables together in communities of people who are payers, are providers, work with justice-involved populations, work with community-based organizations so that we can build the solutions in an organized and coordinated way. But the other thing that we've done is the president has stepped up and said, Congress has laid out, the women leaders in Congress, because let's be clear, it's women leaders in Congress who have laid out what it's going to take to tackle this crisis. And they have given us a roadmap. So let's, while they're working hard to get this legislation passed, let's put a down payment in the president's budget for what it's going to take to deliver on these kind of initiatives. So you've seen the president's budget last year, this year, really lay out a path to fund what's in the Momnibus, because we know all together that's what it's going to take to deliver. It's going to take the legislative efforts in this building, and it's going to take the policy efforts to deliver on the resources necessary to deliver in communities. Now, we're in a situation where, before we've even made the inroads we want to secure those resources, the House Labor Age Appropriations Bill has zeroed out the Healthy Start program. And everyone in this room, again, knows the Healthy Start program is the community-based organization that makes a difference on the ground on infant mortality in community and community out across the country. So there's a lot of work that we have to do together to both secure the wins we already have and then lean into the fight ahead so that women's voices are heard and we get the best possible health outcomes.
Thank you, Carol. All right, Dr. Cernich. In 2019, the Black Maternal Health Caucus hosted then Director Francis Collins for a conversation about NIH's work on maternal mortality. Coming out of that conversation, NIH launched the Improve initiative, which just received more than $43 million in funding for fiscal year 23. Can you describe what type of research Improve is funding and share some examples with this group of especially important findings you're seeing?
Sure. So I just want to say, first off, that conversation with Representative Underwood and Representative Adams was really pivotal and really helped us to launch our implementing a maternal health and pregnancy outcomes vision for everyone initiative. When we launched this, we were really trying to address the rising rates of maternal morbidity and mortality in this country and focus in on health disparities in the populations who best need to be served by this research, and that includes people who are racial and ethnic minorities, people who are advanced maternal age, and people with disability. And in our first 2 years using our own funding, we put at least $20 million in this to support about 58 projects, and those were anything from traditional NIH science to more community reflective science, so thinking about factors such as structural racism and discrimination and the impact on outcomes for maternal health. We also identified the risk that living in a county with no access to obstetrical care, many of you know that as maternity care deserts, and those numbers are growing. Those women who were living there were at a threefold higher risk of pregnancy-related death compared to those who had access to care. And think about that. We're already bad enough, and we have a threefold increase in risk in those areas. When we received our appropriation in 2022 with the support of this caucus, we launched a number of major initiatives, one of which is modeled off of the COVID program where we advanced diagnostics. And what we're doing in our RADx Tech for Maternal Health Challenge is accelerating the development and commercialization of devices, wearables, sensors, diagnostics that can be used in the home or at the point of care in the postpartum period, whereas the administrator noted 50% of the deaths are occurring, and getting that care into places like maternity care deserts where there may not be access. This is an ongoing competition. We now have 9 teams that are really farther forward with their technologies, one of which is looking at postpartum depression, where we know people have a risk of significant morbidity and suicide, to proactively communicate signs of risk and get those folks to follow-up care. Also a risk sensor and mobile app to detect postpartum hemorrhage, which is something that really does drive mortality. Further, our Connecting the Community for Maternal Health Challenge is a $3 million prize that tried to lower the barrier to NIH funding for community groups and really tried to get us into the communities and having the organizations that are directly serving the community do the research themselves. So we've gone from a high level of interest in that program down to 9 teams that are going to be competing in this last phase, and they're actually doing their own research now. So we're watching them go through the IRB process and do their projects, including doula care to address mental health conditions for prenatal and perinatal people or postpartum people, implementation of a community resilience model intervention, and also development of a maternal morbidity risk prediction tool for their community. We're also looking at how we get to dissemination and implementation strategies for effective care with the community, and also to look at how we get to real-world research with our electronic health records to help with maternal health. We're really excited this year because we're going to be launching some of our signature programs, and I know we've talked to Representative Underwood about this. Our Maternal Health Research Centers of Excellence will be awarded this month. And we are going to be very excited to follow up with the caucus and tell them more about this. But this is a national network, and we've gotten into some states that have some real challenges to develop, implement, and evaluate community-tailored interventions to address health disparities in maternal morbidity and mortality. And we're also launching the Community Implementation Program, in which researchers and community organizations work together to integrate interventions of known effectiveness in community settings. So I think this program in particular has been a real highlight for us of how we can better partner with the community to get the interventions to them in a culturally concordant way and actually help those disseminate across the country. So we've been really, really grateful for the support for that.
Thanks, Allison. It's really exciting work. Jessica, I'll come to you next. Last summer, the White House released the blueprint for addressing the maternal health crisis. Many of the things in that blueprint complement and build on investments from the Momnibus and the leadership that the Black Maternal Health Caucus has provided. I'm hoping you can describe for us a few key aspects of the blueprint and the progress that's being made in implementing it.
Yes, of course. And first, would like to join my colleagues in thanking Congresswomen Underwood and Adams for their leadership in advancing policies that will help reduce maternal mortality and morbidity, as well as for inviting me this morning to talk about it. As you all know, maternal health is a key priority for the president and the vice president, who has long been a champion for improving Black maternal health. The Maternal Health Blueprint is the administration's comprehensive roadmap for how we're taking an all-of-government approach and using every possible tool in our toolbox to address the maternal health crisis we're facing. In fact, it includes over 50 commitments from 9 agencies across the government. And for folks who aren't familiar with the blueprint, it's broken up into 5 main goals. First one is increasing access to coverage of comprehensive, high-quality maternal health services, which importantly includes behavioral health services. The second goal also is to ensure moms are heard and are decision makers in accountable systems of care. We're also focused on advancing data collection and standardization, harmonization, transparency, and research. We also, as Administrator Johnson mentioned, focused on expanding and diversifying the perinatal workforce. And finally, we're also looking at how we can strengthen economic and social supports for people before, during, and after pregnancy. And over the last year, we've made great progress. Through the Administrator Brooks LaSure's team, we have driven coverage rates to historic highs, and that includes, as she has mentioned, over 35 states and the District of Columbia in taking up the option to extend Medicaid postpartum coverage for up to a full year. And also just want to highlight that and make sure we don't forget that the administration has helped facilitate Medicaid expansion in 4 states: Oklahoma, Missouri, North Carolina, and South Dakota. And we've also created, thanks to Administrator Brooks LaSure's team, a new birthing-friendly hospital designation, a public-facing recognition of the quality and safety of maternal care in hospitals, which will be publicly reported beginning this fall. And we've worked hard to implement the No Surprises Act, which helps ensure that women are protected from unexpected out-of-network medical bills that can come up during pregnancy, postpartum care, and delivery. And finally, we're expanding maternal mortality review committees from 39 to all 50 states. We're excited about the progress that we've made so far, and we are working to make sure that we continue this progress in the upcoming year. So hopefully we will have more to share next year at this time.
Thank you, Jessica. Carol, I've heard you talk about the National Maternal Mental Health Hotline. It's a mouthful. And I'm wondering, that was a program that is funded through the Momnibus, and I thought maybe you could talk a minute, just because anytime I've heard you talk about it, it's just so very exciting and interesting. This group might welcome the opportunity to hear about it.
Thank you so much, Deputy Secretary, and thank you again to the caucus for your leadership on this issue. I heard Congresswoman Underwood ask Congresswoman Adams earlier about what gives her hope, and one of the things that gives me hope is how embraced this hotline has been. And so we launched the hotline. It's 833-TLC-MAMA. It is 24 hours a day, 7 days a week, a safe space to have a conversation about mental health concerns, what you think might be mental health concerns, among pregnant people, among families. We get calls from family members who say, you know, my family member might be experiencing something, how do I talk to them about it? We get calls from people who are worried about their friends and neighbors, worried about their colleagues, and we get lots of calls from pregnant people, and texting as well. And what it is it's a safe space to have these kind of conversations. We can make referrals as needed, but often what's needed is that conversation. And we have trained experts and counselors and maternal health experts who answer these calls and are making a real difference in individuals' lives. So we're very excited about it. We're also excited about the fact that in addition to running the hotline, we also run the Screening and Maternal Depression program, which is where, in addition to running a national hotline for women to call directly, we actually run a teleconsultation service in a number of states where OBs and other maternal health providers are able to get direct access to mental health clinicians to try to address mental health needs during that OB visit or otherwise in those maternal health care visits, because we all know how complicated it is to get a referral and get transportation and find your way to months later, you know, maybe getting an appointment with a mental health provider. If we can help strengthen the capacity of maternal health and women's health providers to meet mental health needs, we want to do that. And so we're in 7 states now. We'll be in 13 states this year with the new appropriation we got this year. We don't know where we'll be next year based on how appropriations shake out this year.
Thanks, Carol. I also just want to make sure that I'm not keeping you, we're good? All right. Because we could ask questions all day. 5 minutes, I just got the sign. Administrator Jessica mentioned the friendly hospital designation. I know I'm not saying that, birthing friendly hospital designation. I don't know if you want to say anything more about that program and how you're seeing it impact outcomes.
I am happy to talk about it a little bit more. And one of the things that I'm the most excited about the birthing friendly designation is that this is something that we talked about within the administration that has been embraced by the private sector. And so basically, Jessica started to talk about how we've put this policy in order, and it's really to give a signal to parents. This is going to be a place, this hospital, that has agreed to look at their maternal health and to enter into collaboratives with other organizations to try to work to improve quality. And it's a designation that we really see over time continuing to add additional measures over time as we continue to learn more and more about what we need to be making sure that our hospitals are doing. But as I said, this is something we introduced and unveiled, and we have numerous health plans that have also agreed to use the birthing-friendly designation for their commercial population. So in the future, we have an icon on our website, if you haven't seen it, that will be put on provider directories that will be on our website to really give the signal. And again, just appreciate the work that the Maternal Caucus has done to really lift up the work that we've been doing and to make sure that all of the efforts that the administration is doing is really getting out to everyone.
Dr. Surnich, you noted a little bit in your initial comments these investments that you're making directly in community-based and advocacy organizations to develop the infrastructure necessary to do research at the local level. I'm wondering if you can describe a little bit in greater detail for this group sort of how and why you felt it was important to prioritize this kind of work, and what more can be done to make sure that this is part of the solution moving forward?
For sure. We really had the opportunity, because of the expanded funding, to think creatively. And many of you know that NIH is an alphabet soup of grant applications. We have all the R's, the T's, the F's, the K's, the P's, the U's, the whatevers, right? That is really not consumable by the general community. And the other thing is we have a lot of requirements. And what we recognized was to really get to capacity on the ground, we had to rethink how we were coming at that and not put those same requirements on groups that maybe, one, were doing their own research but couldn't navigate our system, or really had the ideas and the trust of the community and could do the work but didn't know how to enter the research arena. And so we decided to use a prize authority, which is a legislative tool that we have, and to directly do some work with the community. And so we launched a challenge. And the first stage was essentially a paragraph. Tell us who you are, where you are, and what you do on a web form. No T's, no P's, no R's. The second one was a page. Tell us what you'd like to do in your research. And through each phase, what we were doing was doing research training, direct mentoring with teams, and telling them a little bit more about how would you engage in research? How would you do that? Both experts at the NIH and a team of people that we work with. And it's been really gratifying to watch these teams develop over time with direct mentoring. We're now down to 9 teams, and they are conducting their own research. They're going through the IRB process now. And NIH has been providing the IRB service for them so they understand how to do that review. And it's going to be really exciting next summer when we announce the winners. And we'll have prizes ranging for those 9 teams anywhere between $100,000 and $300,000 to hopefully build that capacity at the community level so they can continue that work. We'd love to do more of that. It's resource intensive, it's time intensive, but boy, is it fun to watch.
And a super important investment. Thank you. All right, Jessica. Chiquita noted the importance of the private sector partnership on the birthing-friendly hospitals, but we have other private sector leaders, companies from across the country who are really taking action on the maternal health crisis, and a number of them did that in direct response to the Vice President's call to action in this space. So I'm hoping you can talk a little bit more about how the administration is advancing this really all of government, right? We've talked about from the federal side, but how the private sector really fits into this effort that we're all working on together.
Happy to. I see my time is up sign, so I'll be very quick. I just wanted to mention that in addition to kind of obviously the normal cast of characters that we've been working with, HHS, for example, we also have been looking at ways other agencies like VA and DOD can foster increased access and utilization of care services. We've also been working with EPA to figure out how to limit and more fully understand the risks related to exposures to environmental stressors, like air pollution. We all saw the smoke from the Canadian wildfires earlier this year. Also, the extreme heat, which just happened here and continues across the country. So we're looking at that. And to Deputy Secretary Palm's question about the private sector, the president is committed to doing what we need to do here to make sure that pregnant workers and postpartum women have reasonable accommodations. So we recently signed legislation that will expand workforce protections for pregnant and postpartum workers, such as expanding the use of break time and access to private space for nursing mothers, ensuring that they can sit down, have a drink of water, and also have appropriately sized safety equipment and uniforms. And we're working to galvanize the private sector, including with reaching out to leaders, to go beyond what we can do here at the federal government and advance our support for women through research, funding additional programs, and providing supplies and other supports to at-risk women. So I just want to give 2 quick examples. So Pampers, we all know the Pampers diaper company. They supported the March of Dimes in its implicit bias training for 2,500 maternal and infant health workers in high-need states. impacting over 20,000 women per year. And CVS, one of the largest drug and pharmacy chains, supported the Every Mother Counts film series, which is an initiative to improve care for Black pregnant women in 12 safety net hospitals with worse than average outcomes for maternal mortality and morbidity. So again, more work to be done here, but we're really excited about what we've been seeing and the changes that we're making.
Thank you. So I'll just wrap by thanking our panelists, my colleagues. Thank you for joining me. And on behalf of us, our appreciation again to the caucus, to Congress for the investments that you've made, and particularly to our co-chairs, Congresswoman Underwood and Adams, for bringing us all together today for this really important day-long event and the focus on this work, which we look forward to continuing to do with all of you. So thank you very much.